Welcome, students. This is the opening post for week 7. So you know what that means. That means that we are over halfway through. The discussion for this week and next week is the structure of knowledge. This is part 1. Structure of nursing knowledge, rather. I'll have to say that I'm not in a hurry for the course to be over. I'm enjoying it a great deal. Reading your posts, being in conversation with you in responding to your posts, in the Zoom conversations we're having. And what I'm finding is that every week I am challenged to write a paper, a philosophical paper. So I'm working hard too. It's good for me. It's good practice, and I hope that I'm able to be clear and model good practice in these posts, because you only have a week to write your posts too. So starting with an introduction. The articles and the discussions for week 7 and 8 focus on the philosophical underpinnings of nursing and this structural framework that's developed for nursing knowledge. So nursing knowledge and psychiatric nursing knowledge, they are collectivized knowledge bases. We've built it as a collective. Nurses have built it up as a collective. Historically, right? It's occurred at a particular time in history and within the context of particular other worldviews and discourses about science and being a professional, being an academic discipline. The article by McEwen, it's a chapter, and it introduces the structure of nursing science and philosophy. I think it's very straightforward and gives you a nice reorientation. Questions we might ask from the readings, particularly this week, are what worldviews, philosophical and historical contexts are within which psychiatric nursing has developed. Sorry, I think I have to make a change there to my notes. So what are the worldview, philosophical, and historical contexts within which nursing knowledge has developed? And therefore, what are the resulting self-evident beliefs or unexamined assumptions that we have based on that history and those influences? And how can we analyze and critique those influences and not just accept them holus bolus? Not that they're necessarily wrong, just that we critique them, we reflect on them. Nairn tries to reconcile the contradictions between the assumptions of biological science and psychiatric nursing practice in particular. And he uses the philosophy of critical realism. Lines is an example of using a postmodern perspective to analyze the assumptions underpinning evidence-based practice relative to psychiatric nursing. In week 8, we're going to do some more work looking at theories that have been particularly important to psychiatric nursing, such as psychodynamic theories, humanistic theories, cognitive theories. And to do that, I'm going to refer to a book by Stickley and Wright and give you an overview of those theories, which are considered to be particularly influential to psychiatric nursing, like Rogers. And then I'm going to refer to Stickley and Wright again in week 12 in aid of identifying the key elements of psychiatric nursing, key issues in psychiatric nursing. So McEwen, pretty straightforward, standard introduction to philosophical and theoretical underpinnings of nursing and the structure of nursing, which evolved in the last century. The McEwen chapter might help or reorient you to the basic framework of nursing knowledge, starting with the definitions and discussions on what is philosophy, what is science, what is the philosophy of nursing, what is the science of nursing. McEwen also really discusses the patterns of knowing, and you've got that by now. McEwen also highlights debate over whether nursing is a science, and if so, what kind of a science? Because this used to be a really important question, because nursing wanted to be a science. Everybody wanted to be a science. The desire and the efforts of nursing to professionalize in the last century led to a strong focus on empirical science and on the construction of academic knowledge. Nurses wanted to professionalize and authorize themselves as the owners of legitimate knowledge. And to do that, they felt they needed to make claims of being a science and to try to replicate the ways that medicine was able to successfully get authority as a science. And they also used the academe as a way to legitimize nursing knowledge because it belongs to the university, so it was be more highly valued. Now, since that time, there's been a reaction, a strong reaction in nursing, and I'm not sure how many years it's been going on in this century, potentially 15 years. There's been a reaction in nursing against what's now perceived as an overvaluing of empirics and an overvaluing of the academic production of knowledge. So, for instance, we see more literature on relational practice and pragmatic inquiry. And we've seen that in the articles that we've looked at. Nairn. Our readings and our discussions have critiqued the overvaluing of empirical biomedical knowledge. Nairn examines the downside of overvaluing biological knowledge in nursing, and in particular, the predominance of neuroscience and genetics in psychiatry. He refers to Nicholas Rose, and Nicholas Rose is a sociologist who's done a lot of work at looking how we can reconcile both the neurosciences and the social sciences, and how the social sciences can be supportive of neurosciences. Nairn also makes the case that biological knowledge is useful in nursing, and so that it's possible to both use and critique biological sciences in nursing practice. They're not necessarily diametrically opposed. They're not incongruent. Nairn's primary critique of the biological sciences is the tendency towards determinism and reductionism. So take a look at what those words mean and be relatively clear about what they mean. So biological determinism ignores the social determinants of health, as well as political and economic priorities as determinants. That it is biology that determines who we are and what happens. That even emotions and anger, he talks about altruism as being claimed to have biological roots. It's reduced to its biological roots. Now, this is particularly problematic in mental health because, I quote Nairn, the tendency to decontextualize mental health problems and turn them into individual rather than a social problem. Biological sciences tend to be reductionistic, collapsing complexity. Nurses, on the other hand, he describes as nursing as non-conflatatory, I think he made the word up, relational and emergent. So, in the previous paragraph, I talked about how biology can be deterministic. It's looked at for the answer in a simplistic way. In this paragraph, I'm talking about reductionism. Now, to conflate, to tease apart this word non-conflatatory, to conflate, if you look it up, means that you combine two or more ideas down to one. And you lose the distinction and the relationship between the two ideas. We can assume that we can reduce things down to smaller units, that one unit can be held within another. Now, nursing takes multiple diverse ideas into consideration, maintains diversity and complexity. This is part of a relational and a contextual approach to practice. So he says that biological sciences are not necessarily reductionist, but there is a strong tendency to be reductionist. And in mental health, we do tend to see, individuals, for instance, who become angry about something or emotionally upset about something, that may be reduced to the fact that they have a mental illness, not some other cause. And that causes problems for people with mental illness. We also tend to reduce mental distress down to neurotransmitters. And the solution to mental distress is reduced to medications. Now, he also uses the word emergent. Now, my idea of emergent practice is that knowledge and decisions for action are emergent. They arise within interactions with patients, from within relationships. There's a phrase, you make the path by walking it. We don't know what the path is until we're walking it. We're constructed as we're walking it. But you know what? That isn't what Nairn means. Nairn defines emergent as when one level of reality is reliant upon lower levels of reality. Whoa, what's that about? So the concept of emergence, as Nairn is describing, is central to a philosophy of science called critical realism. Nairn makes the argument that the use of critical realism in nursing could solve the problem of reductionism of biological science in nursing. Now, I'm not sure I can do justice to a description of critical realism, but I'll try to give you a rough introduction. Critical realism is a philosophy developed to challenge both positivism and postmodernism. So, roughly, again, very broadly, positivism is based on realism, the belief in fixed entities with fixed characteristics that exist as such regardless of whether we're looking at them or not. Our interpretation of them, they exist outside of our interpretation of them. Now, postmodernism, again, very broadly, is based on constructionism or constructivism. They get used interchangeably. And constructionism holds that what we come to know is always a product of ourselves. What we come to know is always a product of how we come to know it. A product of ourselves and our product of the process of coming to know. And physics has shown this, that the act of observing changes that which we observe. Critical realism retains the idea of realism, that there are actual things out there. Right? Concrete exist outside of us, interpreting them. So critical realism retains realism and solves the problem of reductionism, supposedly, by stating that there are multiple levels of real, that there are somehow separate, multiple levels of real that interact with each other. Oh, the levels of real can't be collapsed, and one level can't be reduced to another. So that sounds like really airy-fairy, but it's actually a bit simpler than that. For instance, our emotional experiences have very real biological bases, right? And that biological basis is a level of real. It's a more fundamental or lower level of real. But our emotional experiences can't be explained by that level of real alone, by biology alone. Nair is suggesting that nurses deal with all the various levels of real without reducing, without collapsing. So for instance, we don't collapse mental distress down to neurochemistry. There are interpersonal, social, and even political reasons, real reasons for mental distress. We can't collapse that down, reduce it to just neurochemistry. I hope that helps. Lines. The article by Lines, on the other hand, is an example of a postmodernist constructivist perspective in nursing. Lines proposes that discourse analysis could be used to analyze evidence-based practice in psychiatric nursing. I studied discourse analysis, and I can remember being very confused, so you're perfectly allowed to be confused about discourse analysis. There's all sorts of kinds of discourse analysis. Lines is using what's called a Foucauldian discourse analysis, and we've talked a little bit about Foucault. And when Lines wrote her article, discourse analysis was not being used by nursing, with the exception of Powers. Forget her first name, but I can send you an article by Powers if you're interested. She does discourse analysis of using NANDA, nursing care plans. Okay, back to discourse analysis. Now, when I look at the literature, the discourse analysis of in nursing is becoming a popular title. So discourse analysis is becoming a trend in nursing research. We have a very strong trend in the lived experience of, or phenomenological research in nursing, not just psych nursing, but in nursing. And now I'm starting to see titles that indicate that people are using discourse analysis as a way of analyzing nursing practice. Now, there are numerous schools of discourse analysis, ranging all the way from a micro level, which pays really close attention to how language is used within interpersonal interactions, to a macro level, of looking at how language and text and practices are used within society. So it might be a macro level analysis of political speeches and textbooks and the structure of institutions, how people are talking about larger issues within society. But there's always one commonality to discourse analysis, whether it's just one on one between two people or whether you're looking at a discourse within society. It's a study of how knowledge, subjectivity, like the self, and social structure, like institutions and culture, how they're produced through human interactions and relationships. So, discourse analysis is a way of understanding, analyzing, getting at how we make meaning, how we make knowledge, how we make each other, and how we make society through our interaction and relationships with each other. It's a tool for trying to get at that social construction. Okay. Now, the other postmodernist line uses is Derrida and deconstructionism. Just very broadly. This is all you need to know. I'm doing him a disservice, but very broadly, it involves an in-depth analysis of a social concept or construct by contrasting it with what's considered to be its opposite as a way of helping us to understand how that idea is structured and where it comes from and how it gets used. Derrida's work is a deconstruction of social concepts to reveal and challenge unexamined assumptions. Right? That which we don't even notice, or that which we take as self-evident. Lyons refers to Holmes, David Holmes, I'm pretty sure is his first name. He is a Canadian postmodern nursing scholar, and his work focuses on a critical analysis of psychiatric nursing practice, in particular within the field of forensic psychiatric nursing practice. Holmes uses Foucault. Holmes argues that a valorization of positivist-based research that's used in producing evidence for best nursing practice strips the humanity from our inquiry, from our research, and it diminishes our humanity. Lyons cites this idea from Holmes. Strictly positivist research, upon which evidence-based clinical practice is based, operates by removing context and removing relationship factors, right? By reducing the variables. So if you look in line, you'll see the standard rating of evidence, a hierarchy of evidence for evidence-based practice. And if you look at it, it's very empirical. So much of the research in mental health doesn't fit very well unless it's strictly pharmacological science, bioscience. So when we use this, when we remove context and relationship in order to do this particular kind of positivist empirical science, it makes it difficult to generalize it to real life and real people's situations. When we have standardized protocols, that makes individual care difficult and individualized care devalued. Once I was asked to design a care map So they were using best practice care maps based on empirical evidence for things like knee replacement or TERPs. And so you just have a form and it shows you what should happen 1 hour after surgery, 3 hours after surgery, 1 day after surgery, discharge. What should be given, what should be done, what should be the outcomes. Now, they wanted me to write a care map for schizophrenia in acute care psychiatry. Nobody saw the problem with that. So, evidence derived from a positivistic empirical science may be usefully applied in some practices, but it works against best practice when applied to relational and holistic practice. And you'll have noticed that the language has changed in the nursing literature from evidence-based practice to evidence-informed practice. Lyne's article, if I remember correctly, was 2001. Things have really changed since then. Nurses have rejected the idea of evidence-based practice from a clinically removed research applied to real people's lives. And if you think back to Doan and Varco, they're talking about how knowledge needs to be produced in practice. So in conclusion, nursing philosophy, science, and knowledge has evolved within social and historical contexts, which have shaped nursing orthodoxy. McEwen describes the foundations of nursing orthodoxy. We'll continue to examine this foundation next week, particularly through the work of Jacqueline Fawcett. Oh, she's the queen of nursing orthodoxy, systematizing nursing. Fawcett refers to the structure of nursing knowledge, but orthodoxy is an appropriate term. Although admittedly, it can be taken as kind of provocative. But if you look up orthodoxy, what it means is it's authorized or generally accepted theory, doctrine, and practice. It fits. And I've given you that was a definition from a dictionary. You can check me out. We've focused heavily on the impact of biomedical science assumptions on the practice of nursing and particularly psych nursing. The nursing literature, though, has really taken a turn away from an emphasis on empirical science and the building of authoritative academic nursing knowledge towards an exploration of and a defense of nursing as a relational, holistic practice, wherein knowledge and practice are mutually co-produced. No theory-practice gap. We've seen this in the literature. Relational holistic practice is being recognized and honored as a foundation of nursing. Yay! And this is really fortunate for psychiatric nursing because overvaluing biomedical science is particularly problematic in nursing practice. An aside. So I worked as an educator in acute care psychiatry, but much of my time, it was part-time and then now it was part-time research, much of my time as an educator and all of my time in research was looking at initiatives that were pushed by the Winnipeg Regional Health Authority, hand washing, mouth care, other kinds of biologically based care were prioritized in psychiatry, even though it's not that they aren't important, but they're less important in psychiatry. And they pushed research and reflection on and attention to psychiatric nursing practice and the practice of relational holistic nursing. Nairn and Lyons give us some examples of using critical realism and postmodernism, respectively, to critically analyze the effects of biological science and the assumptions on nursing practice, and to defend nursing as a relational and holistic philosophical practice. We have underpinning relational and holistic philosophical assumptions that ground our practice. And you are very fortunate to have more backing from nursing knowledge, general nursing knowledge, now for relational and holistic practice that wasn't there 30 years ago. So have fun. I'll read your posts Monday, I think it'll be. And by all means, email me, make an arrangement. We can have a FaceTime or a Zoom if you can't make it to any of the 2 regular Zooms. The Zoom sessions have been delightful. I encourage you to give it a try. Bye-bye.